So change is inevitable. That's why you're coming to CE. So we're going to talk about a lot of things that are changing today. A lot of new weight loss medications out there. How do they compare to some of the older ones? What are the newest guidelines even saying about this? For the first time, we've got actually some guidelines. What about new antibiotics? We'll talk about why you haven't heard probably a lot of continuing education on new antibiotics lately. But what we do have, we will discuss, and whether they're going to be applicable to your practice. And then towards the end, we're going to talk about PreP some, kind of in the middle, HIV, kind of a unique management strategy within that realm. And then we're also going to talk about penicillin allergies, one of my favorite pains in the butt to take care of on a daily basis. So a lot to cover today. I'm excited to be here with you. Just to give a brief introduction on who I am. Yes, I am Chris Bland. I am the Albert Jowdy Professor in Pharmacy Care at the University of Georgia College of Pharmacy. So University of Georgia, big state, 4 campuses. So I'm actually at the Savannah, Georgia campus. So I was hired 9 years ago, well, about 8.5 or so, to help start that campus. So I kind of had the most awkward, weird kind of path to academia. So in 2015 is when I went to Georgia, but from 2001 to 2014 or 15, for 14 years, I was working for the Department of Defense. I was a civilian pharmacist. I did a little bit of everything. So for primary care folks, I love you guys because I get it. I was embedded in a family medicine clinic. I worked a lot with our inpatients, rounded with a critical care team. But there were 2 things I did a lot that I think I really enjoyed the most, and that's why I continue to speak on these topics and research them and publish in them. And that's going to be weight loss management, but also infectious diseases. So when I did this crazy thing in 2015, I had 14 years of federal service, and I was like, man, 1 year away from like maxing out my vacation and benefits. And I said, you know what? This would be a great time to go to academia, right? And my wife did think I was a little crazy at the time. And honestly, it's been the best move I've ever made. I love building things. Even though I got my hands, like, I'm not a mechanic by any means, but I love the idea of building something for the first time. So back in my Eisenhower Army Medical Center days when I worked there, I started what I believe to be the first bariatric surgery follow-up clinic for medication management. So after patients had bariatric surgery, even before surgery, I'll never forget, one of my surgeons came to me, Dr. Choi, he's done probably 1,000 bariatric surgeries. And he said, Chris, he said, I need your help. And I said, okay, I don't know what this is going to entail. He says, I got a lot of people coming to the emergency room with hypotension, hypoglycemia, and quite frankly, I don't do drugs. That's kind of what he said. And I was like, well, I know you don't do drugs. You're a surgeon. Okay. But he's like, no, you don't understand. I don't manage drugs. Okay. So at that time, a lot of our primary care providers were deployed in the Army. And so they couldn't get them in fast enough for a follow-up. So I've really been intrigued with this area. I lost 70 pounds myself back in 2003. So I know the struggles that occur with I probably tried to lose weight a dozen times before I finally had some success. And so I've kept off probably about 90% of that for 20 years. So I feel like I can empathize with patients that are dealing with this issue. I think the issue of obesity and weight loss is quickly becoming its own specialty, in the sense that, now you've got drug therapies that aren't like horrible. Like we're going to talk about some today that quite frankly are pretty horrible. They're just not easy to take and don't really work that well. Then you got others now that seem to be working pretty well, but we need more long-term outcome data on them. And then you've got bariatric surgery. So there are a number of different facets that are going. I don't know if you guys keep up with lay press and stuff, but Weight Watchers, right? You guys remember Weight Watchers? Now they're what? W. I don't know why they changed their name to that, but they did. Okay. And what they've done is they've bought certain companies that actually, a lot of patients will just find them online and get these medications without actually physically seeing somebody in person to get them. So patients find a way, right? I mean, they do find a way whenever they want something or they feel like they can. So there's a lot of rapid moving changes in this area. I've got a lot of data I'm going to cover, especially in this first talk with a lot of studies, because I do feel like it's good to get a sense for all of these areas. But I'm excited to be with y'all. We'll take some breaks throughout. Feel free to ask questions. Glad you're part of the ULS family. I've been speaking for Charlene for years, and I absolutely love it. So I hope by the end of this, you've enjoyed the education, but also felt like this is kind of a smaller type gig where you can get to know people and really just enjoy being here. So some of our objectives, if we don't have objectives, we don't get CE, right? That's how it works. Okay. So learning objectives, we're going to review the risk factors and criteria within obesity. What does it really mean? Okay. So we're going to put some numbers behind that. Second, we're going to describe the appropriate populations for weight loss. Not everybody is an appropriate candidate for some of these drugs and even surgery in that case. I'm not going to talk as much about surgery today. I do a whole talk on surgery at a different ULS event with that. We're going to delineate the key characteristics and then apply that within a couple of patient cases at the end that really I think is going to make some of these details of these drugs, kind of the takeaway points, really, really important. So obesity in America. So you go back to 23 years ago, the prevalence of obesity, and I'm going to show you some maps here in a second, was about 30%. So we're up about 10% even from 20 years ago. The prevalence specific to young adults is really eye-opening. When you see this, 1976, the year I was born, 6.2%, okay? Now it's nearly five-fold increase in obesity over really about a 30-year period, 30 to 40 years, so about 2% per year. And there's a lot of reasons for that. What are some of the reasons for this, you think? Fast food. It's fast. I don't know if it's food, but it's fast, right? Phone. You showed me your phone, right? The iPhone. I'm an Apple shareholder, okay? It's a great product. Very addictive. Very addictive. Sometimes you're scrolling, you're like, man, 30 minutes just went by? Yeah, it's crazy. I have 3 kids, 2 daughters and a son. And my son, thankfully, like we don't have any video game system in our house. He doesn't have a phone yet. He loves to be outside. He was fishing yesterday, okay? And so there's a lot of things, and including adults, that this impacts. So we know it's a major problem. It's here. Childhood obesity continues to increase. It's expected to be, and I read this in an article recently when I was looking at some of the newer agents that we're not even going to talk about that are real still in the pipeline. $100 billion business. 100 billion. It's huge, right? And so that's why I say we're right in the midst, kind of the upward movement up, and what we're going to see in this industry with these drug therapies. I think a lot of things are going to come about before we finally settle them out. So kind of some more points to this. So 50 million Americans are obese. That's defined by BMI of 30 or more. 12 million of these have a BMI greater than 40, class 3. Over 500 million diabetes patients are expected worldwide by 2030. And when you think about that, I do a whole separate talk on diabetes management, and I say 500 million. I use the same slide, right? There's about 340 million people in the United States. So imagine every person in the United States has diabetes. What would that do to the healthcare system? It'd crush it, right? There's no way it can be sustainable. And so when you think about the comorbidities, you think about renal disease, right? 7% of Medicare's budget is devoted strictly to end-stage renal disease management, dialysis. So anything we can do to slow dialysis happening, a year, 2 years, that's huge from a financial standpoint. So anything we can do for that is important. And so that's why obesity itself, you know, I think in a lot of pharmacy schools, medical schools, PA schools, nursing schools, I don't know that obesity is taught as a standalone topic. You know, we talk about hypertension, we talk about diabetes, but we've started in our curriculum, we have an obesity management lecture, and it's been really, really important. And our students have been very appreciative because when they go to work and they're interning, what are people asking about? Right? They're like, man, should I take my Mounjaro journey? right? And I don't even know what that is, but we're going to find out. I will tell you what that is later. Okay. So morbid obesity, of course, associated with all of these, including cancer. Obesity is directly associated with cancer. So we'll talk about that. Now, this is one of my favorite slides I have to include in every talk I do on obesity, just because it's eye-opening, right? A picture's worth 1,000 words. You look, and this is specifically after bariatric surgery, but quite frankly, it applies to anybody that loses a large amount of weight. You start dropping things like your cholesterol level, migraines, okay, reflux disease, depression, stress, urinary incontinence. And these are things, of course, along with things we know well, like diabetes, hypertension, glycemia. And it ultimately results in quality of life and mortality. So I enjoy doing something that probably is not a smart thing to do, but I enjoy doing it. And that is, I tell my Uber or my Lyft driver what I do for a living, okay? And so once they find out you're a pharmacist or a physician or a nurse or a PA, they will ask you lots of questions. And that's what I love. I love those questions. But it was interesting. Yesterday, my Lyft driver, her daughter had bariatric surgery and she lost 180 pounds, okay? And had multiple venous thromboembolic events afterwards, right? Because that can happen with obesity, rapid weight loss, et cetera, not moving around. So she said, but you know what? She said she would do it again in a heartbeat, wouldn't even flinch, even if she knew she was going to have to go through all this stuff. Why? Quality of life. She said, I can actually be active with my children and not just sit there and watch them, right? So this is a big deal with patients. I used to ask every bariatric surgery patient, why are you doing this? Like, why are you, what brought you to my office this day? Because I would see them along with our bariatric surgeons. And quality of life was like the number one answer. The number two, you want to know what the number two was? Avoiding drugs. Believe it or not, patients in their mind. And I know it has nothing to do with commercials, where they list like 800 side effects of each drug, right? Even if patients didn't have it in the study and the FDA mandates that they report it, right? So it's interesting. So why do we hear so much about BMI? Right? Body mass index. It's because it correlates really well. It's not a perfect tool, but it does correlate well with things like waist circumference, abdominal visceral fat, and fat mass. And so it's really the best thing we have. They're 5 years, 10 years from now, we're going to have better things. We're probably going to have, I think with obesity growing as its own specialty, we're going to see a lot more invasive kind of evaluation of a number of things. But right now, BMI, probably not forever, but it is what we got right now. So just as a reminder, BMI is greater than 25, considered overweight up to about 29.9. Then you get to 30, and that's class 1, 35, class 2, and then 40 or more is class 3. So as I go through these studies, keep these a little bit in mind, because as we go through, it'll give some BMI categories. A lot of times, it'll give a weight. And that's going to be a lot more for y'all, I think, to be able to understand some of the data that we present. So, these are great, but I felt like, what? Let's go to the CDC website and see what they show, right? And I found this really cool slide set. Y'all like maps? Here's a map. So this is 2004. What were you doing in 2004, 19 years ago? Oh, working, right? A lot of you are like, working just like today. That's true, but 2004, a big thing had happened. I had been at my job for the military, and I got transitioned to the ICU. I rounded with the ICU every day for 12 years. It was a lot of fun, but that happened in 04. Well, in 04, you can see a lot of kind of greenish color on this map, kind of a bluish green, kind of color. It's kind of faded a little bit on here, but not nearly as bad. But as you go from 2004 to 2010, look at that purple, right? So the purple is more obesity, okay, right? So, you go from this to this, right? And then that's 2010. How about 2016, right? So the whole point of this is that more and more, it's easier to hear numbers, but sometimes a picture's worth 1,000 words. I mean, these are all essentially county level data within these states. And so you see the amount of obesity is just present. It's everywhere. It's everywhere, especially in the Southeast, right? Now, let me give you a pro tip. How many of you ever been to Savannah? Hope you had a great time. Did you have a good time? I love the city, okay? I have the best job in the world. I get to work for a great university in Savannah. Now, Athens is a cool town, but Savannah, in my opinion, is better, okay? But, you know, everybody, when they go to Savannah, they want to eat at Paula Deen's restaurant. Y'all ever heard of Paula Deen? She's a lovely lady, okay? Don't go to her restaurant, okay? There's like 30 better in Savannah. Maybe 300, okay. All right, that's my pro tip for Savannah. You know, she got diabetes. She's lost like 40 pounds. She looks fantastic. Nothing against her. There's other restaurants. All right. So when do we talk about drug therapy, right? So first thing is, has initial weight loss efforts failed? Now, here's the cool thing. I'm going to go through these studies. When you enroll somebody in a study and they're in the placebo group, they lose weight because they're being watched, right? They're being evaluated. That's why Weight Watchers, now they're W, okay? It works, right? When you know you got to get on the scale and be accountable to somebody, it does work. So when you're accountable to an investigator, it works. So they do lose weight. So a lot of times you'll see studies, they have run-in periods. They do lose weight, but it doesn't stay, right? So that's the issue. It's the yo-yo effect. I told you I tried 10 times to lose weight, and it wasn't until about the 10th time that it actually clicked, okay? So 5 to 10% weight loss initial goal, because we know this is going to decrease the risk of type 2 diabetes, hypertension, dyslipidemia, diet, exercise, and behavior modification. So all of those things together are really what we need to try to give it the good try, usually a good few months to give a good 3-month trial. And if it doesn't work or it hasn't happened, gotten the results they have, that's when we start thinking about it. Now, most of the studies on weight loss medications typically have these criteria: BMI of 30 or more, so that class 1 obesity, or a BMI of 27 or more with a comorbid condition. So that's going to be things like hypertension, diabetes, obstructive sleep apnea, something that is like, okay, we've got a manifestation of this obesity. This is not just obesity alone, okay? So those are the times we consider it. Now, there are a few pearls I want to talk about before we dive knee deep into these slides. So the first one is weight loss benefit almost always stops after you stop the drug. So one of the things we're seeing, and patients will ask this all the time, you know, why? Because of affordability, right? They want to say, okay, I've been on this for a year. What's going to happen if I stop this drug? All right. And most of the time they gain the weight back. All right. And you think about it, especially with some of the drugs we talk about, what they're doing is they're working on the central nervous system. They're working on like the GLP-1s. Patients just do not feel hungry when they're on those drugs. Okay. One of my staff members is on one of the drugs we're going to talk about. And I was like, you know, why do you think you know, she's lost like 50 pounds. Okay. She's like, I just don't feel hungry and it doesn't bother me. Okay. So, but when you take that away, that goes away as well. So therapy should be stopped if 5% or more weight loss does not occur. 5% is a low threshold. Like if you're not losing that amount, especially with some of these newer agents, it's just not the right drug for you. Okay. Because you should be losing more than that. Third, these are not indicated for pregnancy, right? Pregnancy, one of my best friends, she delivered her first baby yesterday, healthy baby boy. Okay. And I saw her last week. And they were inducing her yesterday because they said the baby, you know, they were a little concerned because she had not gained that much weight with her pregnancy and they were worried about the size of her child. Fortunately, child's fine, 7 pounds, 5 ounces, APGAR score was great. Everything's great. Okay. But again, because of that, we don't want patients losing weight during pregnancy. Significant side effects with older agents. We're going to see this. I'm going to go through that. My Lyft driver yesterday, she was telling me all about her Fen that she used to take. Y'all remember Fen, right? Fen for yourself with your heart valve, okay? So it used to fry some heart valves. So anyway, there are some older drugs out there, but a lot of them are full of side effects. Most effective agents generally require slow titration. So especially when you get into the injectables, GLP-1s, GIP drugs, those specifically require a slow titration because of the GI side effects. So the reason they work, GI. The reason they cause side effects, GI. So a lot of these are titrations, especially with the once weekly drugs. Those are usually titrated over months before you get to a final dose. Most study participants are predominantly female. I guess we're okay, like just being obese as a man, I guess. But most of the studies are that, and that kind of mirrors bariatric surgery studies. 70 to 80% of bariatric surgery patients are female. Okay, so that's something to keep in mind as you're going through this data. I think we need more data in men, for sure, especially when you talk about men and cardiovascular outcomes. So these are some of the drug pearls before we get in there. Yeah, sure.
Then I'm curious, do you allow them to try?
Okay, for the 5%. Yeah, so the question was, and those of you on Zoom, welcome as well. And I teach from Savannah. I teach to 4 campuses. So I'm teaching to Albany, Augusta, and Athens. So welcome on Zoom. So the question was, how long do you wait to give these drugs a trial? I personally think somewhere around 3 months is very reasonable. Especially 5%. Now, I will tell you, though, that, and I'm going to get into this with some of the newer drugs that are coming out, I don't know that 3 months is the right answer. The more I read these trials, it might be 6 months, because depending on the titration schedule, that may take a while. And we know that this is dose related. For some of these agents, they do lose more weight on a higher dose. So it could be reasonable to wait longer. A lot of that's going to be talking with the patient. Are you tolerating this drug? Or is it causing any major adverse effects that you just would rather not deal with? And if they are tolerating it fine and they're willing to pay for it and they're willing to give it a try, 6 months is very, very reasonable in my opinion. So
What about the benefit?
yeah.
Really bad.
Yeah, I would say the statement was made, there are other benefits besides the weight loss. I hope so. I haven't seen great data there, and that's one of my you're getting to my closing act, is I do talk about that's where we need more information. But yeah, it'll be interesting to see outside of the OB, because I think about like every diabetes drug, when it goes before the FDA, it's no longer acceptable to just say we lower A1C by X. You can't do that. Like you can do that, but you have to do a follow-up trial that shows what happened to these patients' morbidity and mortality. And so I think we're in the same boat with these drugs, some of the new ones. But I agree. I'm hopeful. I'm very hopeful. And I don't see anything why not. But ultimately, when we're, because you saw how many people are on that map, right? $100 billion business. So we can't be, remember Women's Health Initiative? Let's give every woman after menopause estrogen. That didn't work out well, right? So I think we need that data. Yes. Let me see here. Are you talking about on these? Oh, yeah. I didn't know if you were looking for a specific. I don't have a specific comment on that. Did you want to make a comment? That's a good point. So I see what point you're making. Your point is, depending on where you draw the line, a number of people then qualify as obese. Yeah. I think there's no doubt that, sometimes that happens. I would say also, though, that the weight definitely has increased over time for sure. Yeah, it's an interesting point. So potential drug therapies. We're going to go through each of these. I'm going to give you the data. It's a little granular, but I got to do it. Okay. But I will make it fun. I promise. All right. As much as I can. All right. At 8:30 on the West Coast when I'm East Coast. I was up at 4 this morning, y'all. Ready to go. I wanted to come in here and call y'all. And no, I'm just kidding. But so let's go through some of these. All right. Y'all remember Xenical? Orlistat, baby. Well, that'd be a horrible present, right? Or Ally, right? I think they should have nicknamed it Enemy, right? Instead of Ally, okay? Now, this drug, it was like the first one, right? People came out and, people would lose weight. Y'all remember? It was like, Xenical, man. Yeah, okay. So it's a local drug. It doesn't work systemically. It works locally on the gut, right? And basically, it's like I call it the punishment drug. If you eat a bunch of fatty food, it will punish you if you take this drug with it, right? So flatulence, oily stools, fecal urgency, just a lot of troublesome side effects with this drug. It is one of the few drugs approved at a BMI of 25, so a little bit lower than some of the other therapies probably because the systemic side effects are pretty minimal. It's more the local GI side effects that dominate. But you can see the overall weight loss, 3 to 5 kilos on a good day, a good patient. So this is going to be lower than what we see with some of these other agents. And the tolerability is just pretty hard to talk. Almost everybody stops these drugs eventually. The other thing I worry about is it does decrease the absorption of a lot of your fat-soluble vitamins. So your vitamin K, your A, D, E, and K, patients are on these. You think about the bad old days where everybody's on Coumadin all the time. So affecting that, you could see that. Synthroid, you have to take 4 hours before or after. And then cyclosporin, a really important immunosuppressant drug. Actually, Xenical or Ally, whichever one you're taking, can decrease those concentrations. So bottom line on this drug, minimal weight loss with low tolerability. Do y'all have patients that are on this drug? I'm curious. No. All right. Yeah, I haven't seen it in a while, and I haven't been asked about it in a while, but it is in the guidelines. So the guidelines were published last year, first time for like overall weight loss medication management. I think they're going to have to be updated like yearly, right? Because you think about hypertension guidelines, they're updated how often? Like 7 years, 8 years. I remember when y'all remember JNC 8 came out? I called it JNC late, right? Because I was waiting on it for years, and then it finally came, and it's like, wow, this is something. I think this is going to be like HIV or Hep C, where updates are happening yearly, right? They're going to have to do, or COVID. Sorry, I didn't mean to say that, but COVID updates happen sometimes monthly, depending on what was going on. So I think that's where we're at with obesity management. We're going to have to see these updated pretty often. Now, sympathomimetic amines. So these are the oldest drugs used in clinical practice, sometimes inappropriately, not even for obesity, to keep them up. We had 2 surgeon residents that got in trouble for prescribing Adipex to each other, right? And they were caught and delayed their graduation, right? So controlled substances, they definitely have addiction potential. Phentermine, Adipex is by far the most common we see. There is some diethylpropion out there. But remember, these are only FDA approved for a 12-week course. And so what I tell patients is the longer you're on these, the side effect profile definitely starts to predominate. And once you stop them, the weight's going to come back. And that was the conversation I had with my Lyft driver yesterday, among with other patients that we've had this. So patients tend to use these much longer, but that's much more than the FDA label because of the concern over these cardiovascular and central nervous system side effects. Insomnia, hypertension, you think about patients, they're combining these sometimes with other over-the-counter meds. They're also on Sudafed long-term or something like that. So we can see some pretty pronounced hypertension episodes with these drugs. The weight loss doesn't seem to be as much. By the way, that's the reference for the guidelines that I mentioned earlier, the Grunwald paper on gastroenterology. So not a primary agent by any means, a lot of non-adherence due to side effects. So by themselves, we don't see them conditionally recommended very highly. There is another drug we're going to talk about in here in a second, is combination, which gets a little bit more play. And in fact, we'll go there now. Qsema, have you guys seen this? Yes. Yeah, so the question was, what side effect profile? The insomnia tends to get better in what I've seen with patients, but the hypertension tends to persist. Because you think about it, you take Sudafed, like if you took Sudafed every day, in perpetuity, you're going to see some hypertension. So it's mainly, that's a great point. That's a great point. So the point was, what about if they lose weight? Sometimes that does happen. Yes. And in fact, you're reading my mind because I'm going to get to some studies here where you would expect that, and then it goes down. And in fact, we're here. We're actually here. It's in this studies that we're going to talk about. So, but in some patients, it does persist. That's why this is a highly individualized area. One patient may respond a lot different than another. And, too, a lot of patients, even when they're on the weight loss meds, they don't just do that. They go and do more exercise than they normally were doing. They eat healthier than they normally were doing. I think that's a benefit of these. Some patients don't use it as the magic pill, so to speak, where they're only, that's what we used to tell our bariatric surgery patients. We were like, this is a tool. This is not the end all be all. Like, you can still gain weight if you overeat. I got to tell this story. I had one patient, not kidding, bariatric surgery. Next day they came back, right? And basically they had blown out their anastomosis. Guess where they went? Waffle House. They came in their bowel, man, scattered, smothered, and covered. That's all I can tell you. It was bad. It was bad, right? I know it was a bad joke. So anyway, hash browns. All right. Apparently not a lot of Waffle House people. That's good. That means you won't be obese. So Qsema, have y'all seen this? Topiramate. Okay. So phentermine and topiramate, interesting drug. A lot of CNS potential here with this drug. So it's a controlled substance primarily due to the concern with topiramate, some of its side effects. It's also contraindicated in pregnancy. And so for that reason, that's why that REMS notification notation by the FDA is there. Does have longer term data compared to phentermine alone. Weight loss is definitely dose dependent. There's a titration schedule you can see there. As you can see, it's months. So that's the big thing with patients, and a big counseling point for them is that, look, I know you want to lose weight tomorrow. I know you want to lose weight 2 days from now. But in reality, you got to give this time with all these agents. I mean, even the injectables, many of them take weeks and months. Now, they will see weight loss, but the peak of it, you really have to give it time to get to the highest dose that's going to be able to do that. So these are the dosing schedule here. Again, phentermine and then the pyramate. Now, most of this efficacy is based on 3 randomized controlled trials. So Allison trial, the Gaddy trial, and the Garvey trial. The Allison trial had the lowest, or I'd say the highest threshold for entry, 35 BMI or greater. So pretty high, class 2 obese, whereas the Gaddy and Garvey trials had some range. The other thing, kind of a clinical pearl that I think is important when you're evaluating any of these weight loss trials is, did they include diabetes patients or not? Because in most of the trials, if the patients had diabetes, they will lose less weight than if they did not. So you can't really compare drugs unless you compare the trials kind of apples to apples. Like, okay, what was their population? What was the BMI? What was the weight? Did they have diabetes? Yes or no? And so once you do that, then you can kind of gather some good information and really start to compare these. So the last trial there did have diabetes in there, the Garvey study. The duration of each of these studies was about a year. So that's a longer term than the old phentermine studies that were only 12 weeks in nature. All patients receive caloric restriction. So you'll see this throughout the studies. They try to restrict their calories by at least 500 from what they were normally doing previously, okay? Lifestyle counseling, it's fascinating, y'all. I just saw a paper published 2 days ago, okay? I don't know who did. I haven't done the details. I just read the headline. I know you shouldn't do that, all right? But this one's kind of hard to mess up. You'll hear it. They asked patients, what was their A1C goal? And nearly 1 in 4 couldn't tell them. Couldn't tell them. I don't know what my goal is. I just take this drug, right? So I think it's important to know practical goal for these drugs in these patients. So mean data, 33,000 patients. So what I was getting to is a lot of patients have never had good lifestyle counseling before. They've never had good exercise counseling. You know, what does that look like? They think exercise is going to Gold's Gym, and like they don't want to do that. I'm like, no, it could be walking with a good pace around your neighborhood 5 days a week. That's what I do to keep the weight off. I do lift weights when I can, but mostly it's just walking. So here's another important point. Look at the average weight, about 100 kilos. Okay, so anytime you're interpreting, you're going to see a bunch of results come in the next, few slides. Keep in mind, average weight in these trials, about 100 kilograms. Sometimes a little less, sometimes a little more, but it's right around 100. So when they say 15% weight loss, That gives you an idea. They're losing about 15 kilograms. Okay, does that make sense? Yeah, it's an easy way to, it makes it easy for us to interpret and kind of carry these across. So in the Gaddy trial, so if you remember the Gaddy trial, no doubt they had 2 or more comorbidities, but they also had BMIs up to 45. They had 6.5% weight loss compared with placebo. The best data is for that highest dose. So that's why we want to titrate them if we can and get them to that. 2 outcomes you will see a lot. What percent of patients lost at least 5% of their body weight? What percent lost 10% of their body weight? And some of them will have 15% of their body weight. Well, that's a lot of weight, okay? So FDA has also approved this for 12 years and older. The guidelines support this as a conditional recommendation, moderate certainty. So basically what that means is it's okay. It's not great, but we're moderately certain that this works for most patients as long as they can tolerate it. Now, another point with this, and this kind of gets to the question back here. What was your name back there that asked me about the hypertension? What do you do? Awesome. Great question. You're thinking 8 in the morning. So overall discontinuation higher than placebo. All right. Yeah, you would, not surprising, right? But here's what was interesting. From the hypertension standpoint, about half of patients had hypertension in the Gaddy trial. Look at the reduction in blood pressure. So it actually reduced because they were losing weight. So depending on the patient, if they are losing a good amount of weight, that could override any of the drug-related hypertension that may happen on the sympathomimetic side. So when you get up to that 15 milligram dose, you saw about a 5 millimeter reduction in blood pressure. That's a lot. That's a lot. And that is definitely enough to cause benefit. And I think that was your point, what you were mentioning earlier about effects on hypertension. More patients in the treatment group required blood pressure med discontinuation because some people had an even more pronounced decrease in their blood pressure. And that would say, okay, well, I need to drop one blood pressure medication. I'm not sure which one, but we'll drop one of them. We work through their comorbidities, figure that out, and do that. That was my favorite part, man. People love coming to my bariatric surgery clinic. They loved it because they were like, what med are we dropping today? It became a deprescribing clinic. That's really what it was. And so we published a lot of data on that, deprescribing, hypertension, diabetes, you name it. So should be discontinued 4 days prior to anesthesia. There is some refractory hypotension that can occur due to catecholamine depletion. And so we don't want to do that right before they go in for surgery. Topiramate, just to keep in mind, pharmacists, we call this Dopamax, okay? toPOmax, right? So a lot of loopy CNS type weird side effects, paresthesias, dysphagia, concentration, cognition, and it does have some kidney stone potential. So you definitely want to tell patients if they're going to be on these, this is a major setup for kidney stones because A, the drug causes it, B, they're exercising more. And I haven't walked around Vegas. I plan on doing it today, but it's going to be like 100 or something. And man, it will jump on you rapidly if you are not drinking a lot of water. So counseling patients to drink a lot of water with this drug, especially in areas of high humidity or just high heat in general. So they can get a kidney stone pretty quick. So if they had a history of that, I'd be a little leery. All right, Contrave. Now this is naltrexone and bupropion, opioid antagonists, and antidepressant. Any of you prescribed or seen this? Contrave? Okay, quite a few. All right. So naltrexone, bupropion, I put the schedule here straight from the package insert. I love cutting and pasting from the package insert. Why? So like New England Journal, they don't allow you to cut and paste anything, right? Because if you do that, that's a copyright violation, right? Because they own the journal. Now you can get permission. You know how much that costs? Like if I asked Charlene, can I put this in my talk? Can you pay for it? You know how much it costs? At least $500 just to use their table. It's ridiculous. But why do I put this in here? Because I can. Because you, the taxpayer, paid for this. This is an FDA thing, right? So anything the FDA, the CDC, All of that. You can cut and paste. Why? Because you paid for it. That's a true story. So I love taking snapshots of an FDA document, or like I do a lot of talks on antibiotic resistance. They have a 180-page document. You can do that. So I took this straight from there because it's pretty simple, right? Weeks 1, 2, 3, and 4, you're basically adding 1 tablet a day. 1 in the morning, nothing in the evening. Then you go from 1 in the morning, 1 in the evening. Then 2 in the morning, 1 in the evening, 2 and 2. So 4-week titration. Naltrexone, bupropion, 2 drugs you're very familiar with. Wellbutrin, right? So mean age, again, somewhere around 43 to 60. Look at that baseline weight, 100 kilos. It's like magic, okay? Almost every trial. Now, some of them would be in the 90s. Some of them would be like 110, but it's pretty close, all right? Waist circumference, 110 to 120 centimeters. This morning, as I was drinking coffee, I made sure I calculated right. 2.54 divided, it's about a waist size of about somewhere around 43 inches. Okay. 3 studies included diabetes. The others did not. Again, hypocaloric diet with exercise included. Now, the Wadden study encouraged higher intensity exercise. Now, they didn't get into a lot of details about what that was. I don't know how effective that was. I don't know if it meant like go hike Mount Kilimanjaro, or, go walk the strip, in 100-degree weather, get to the sign and come back. I don't know what it was, but it was more running, probably some jogging, et cetera, for more vigorous. So the newest guidelines, the Grunwald paper, they actually put all these studies together, 25,000 patients. That's a lot, right? And the weight loss compared to placebo, about 3 kilos. So not like when you take all comers, that includes diabetes trials, it's about 3 kilos. In the non-diabetes patient, it's going to be more, okay? And when they look at, those are those outcomes we're looking at. How many patients had a 5% or more total body weight loss? How many had a 10% total body weight loss? 15%. What was the relative risk that this drug would do that over placebo? It was statistically significant. So the way you interpret a confidence interval, okay, you see all these numbers. If the confidence interval, when you're comparing 2 drugs, right, includes 1, it's not significant. Okay, so none of those include the number 1, 1.00, right? That means no difference. So you can see that the relative risk for losing that weight is about twice as much at 5%, 10% total body weight, contrary of about 3 times over placebo chance, and then nearly 4 for 15%. So it's just kind of an interesting way of looking at these studies, interpreting them overall. A lot of discontinuations, about 1 in 4 in these trials. So nausea, vomiting, headache, dizziness, those are some of the major side effects. I don't understand the depression one. It's listed. I checked it 3 times. Didn't make sense to me. They're on bupropion. I don't know. I don't get it. But it was there. It was mentioned. But definitely the GI type side effects, the serious ones were not as different. So a lot on this slide. Let me pick out a couple things that I think you need to know. So about half of the patients lost 5% of their body weight after 56 weeks. So these trials were about a year long in management. Inappropriate for those requiring opiates. Remember, naltrexone, can't give, somebody's on chronic opiates or intermittent, not the greatest drug. I just found out yesterday that my mother-in-law been on hydrocodone for a month. I'm not real happy about it because I'm going to find out why they've got her on and she takes it continuously 4 times a day, right? So she would be by the way, she's very obese, okay? And we're working through that. She's really trying hard. But she would be a terrible candidate for this drug because she's on hydrocodone right now. And she has back pain and she's on a blood thinner. So I'm sure nobody wants to give her an NSAID, which I get, right? But I'm like, we don't need to give hydrocodone. So we're waiting for an MRI. Takes forever, right? So these are some of the problems we face in this. So that would be a population we would not do that. So a large meta-analysis looked to say that this combination seemed to be one of the more effective agents when you look at among the older agents, keeping in mind GLP-1 agonists were not in this data set, okay? So of the older drugs, that's what we see. Okay. Oh, there we go. Okay. Saxenda. Man, I remember when this drug came out. Now we're going to get into, I call it old drugs a little old, and then new. Okay, that's kind of what we're looking at. All right. So we're done with kind of the old drugs, or I would say older drugs. Now we're getting Saxenda. It's been around a little bit, the weight loss part of this. So liraglutide, of course, the diabetes version of this is Victoza. Okay. But these are higher doses. So it's FDA approved for adults, GLP-1 agonist. Oh, man. I knew about GLP-1s before they were cool. Because in bariatric surgery, when you get bariatric surgery, we won a research competition. We measured GLP-1 levels in patients pre and post bariatric surgery. It was amazing. Their GLP-1 would go through the roof. It was amazing. So GLP-1's pretty amazing pharmacology. I love the pharmacology of diabetes drugs. Even SGLT2s, I love them because if you understand it, you understand everything about them. So these are FDA approved. Again, this is the 2 criteria we mentioned earlier, BMI 30 or more, no questions asked. 27 or more if you have a weight-related comorbidity, obstructive sleep apnea, hypertension, diabetes, etc. So FDA approved for peds even. So this is relatively newer, but 12 years and older, body weight of 60 kilograms or more, or an initial BMI of 30 or greater corresponding to adults. Now, dosing. This is where we get into the titration because the major side effects, most common of all GLP-1s is nausea, vomiting, diarrhea, right? Y'all have seen that in practice, right? And if you titrate slowly, you can decrease some of the incidence of that. I was talking to my patient the other day. She had been tolerating the GLP-1s. We were on like the 4th titration and she was starting to get a little bit of nausea. So we were taking the titration a little bit slower because she was losing a pretty good amount of weight on that. So we'd start with 0.6 milligrams sub-Q weekly. This one's a weekly titration, okay? Because what we see here is a number of the different agents are going to be dosed weekly, so their titration is actually monthly. So it's a little bit longer. So because of the dosing schedule with this being daily, then the titration is weekly. So it's a little bit quicker than some of the newer once weekly agents. So when you look at efficacy, 11 randomized controlled trials, 3 of these had intensive exercise, lifestyle modification, behavior counseling, hypocaloric diet, pretty classic for all of these, 150 minutes of weekly exercise, okay? That's hard to do for some patients. That's hard for me to do, right? So that's essentially 30 minutes, 5 days a week, right? I try to do that with walking. We have, my house sits on almost like a pond, and it's a mile. It's 1.1 miles. If I go all the way like a racetrack, okay? So I try to do 3 laps, and it takes me about an hour, depending on how fast I'm going with my wife. Depends on how heated the conversation is, or how, not heated, excuse me, wrong word. Emotionally involved. It's usually about our kids. All right. Sometimes laps go fast. I mean, it's funny. Sometimes I can do it in 17, 16, you know. So several studies. Here's what I was talking about. Run-in period. This is awesome. They'd run them in. They're like, all right, we're going to give you a trial run. See if you're going to stay in this study. Weight loss was about 6 kilograms even prior to entering the study, right? So it shows you people are motivated, right? They do it. So it's pretty fascinating. So about 4,000 patients. Look at that mean weight. Like clockwork. Isn't it fun? 100. That's an easy thing you can remember, right? They're about 100 kilos. All right. Most studies, though, did not have diabetes patients because, remember, Victoza already had an indication for diabetes. They were using it for diabetes, right? In fact, of the GLP-1s, you can make a great argument Victoza has the most robust data for diabetes. Some others do now, but they were one of the first, okay? So most studies do not have diabetes, and that was intentional because they're trying to get an indication for non-diabetes patients because they've already got Victoza for diabetes. Okay, so they didn't really have a huge interest in that at the time, but now could be growing, not sure. So average of 5 kilogram weight loss compared to placebo. If you look at all patients over 9 trials, some lose more, a lot lost more, okay? So you look at more likely to achieve that 5% total body weight loss, 10% and 15%. Statistically significant for all of the Saxenda or liraglutide patients. So pretty good data. Don't have the CNS side effects like you do with some of the agents. don't have the cardiovascular hypertension type side effects that we see. So overall, if they tolerate the GI side effects, patients stay on these for a long time, okay? And that's why I think there's so much interest in these, because there aren't, even if they have some, y'all have had lots of patients with nausea and vomiting on these, right? Do they keep pushing through it? Yeah, they do. They absolutely do. Now, if they sniff one little headache from any other drug, they're stopping it, right? Atenolol, oh no, that causes headache. No, I'm out, right? Why do they keep going? They're losing weight. It's like the one outcome they really care about. See, it's funny, right? It's like, what do we care about? We care about weight loss. I mean, I definitely do. But I care about you having a stroke. I care about you, getting gallstones. I care about you having a heart attack. So I think this is going to be it's now like obesity is like the carrot. We're hoping these drugs do those things that we really want and what we want for the patients. And that's yet to be determined in some aspects, but that's really what we're after. So it's fascinating. We got to get insurance companies that's what they're waiting on. Okay. So safety wise, again, a lot of GI side effects, but patients rarely stopped, at least in some of these trials, they did stop. And I'll show you some of that, but most patients tried to push through and tolerate this. Pancreatitis and gallstones were still pretty rare. So in summary, good weight loss agent, good tolerability, except for the GI side effects. Most patients tolerate through it. Slow titration for that. Sub-Q option. 5 years ago when I gave these talks, I'd be like, ooh, big deal. Sub-Q PO. I'm not as convinced anymore. I think patients are perfectly fine with the sub-Q. Some patients have told me they think the sub-Q works better than the PO, even though there's no data to support that necessarily, but they feel like they're getting something. Like I feel the pain, right? I mean, it's true. I used to have to train people how to take Bidurion, right? Y'all remember that one? Man, it was like a pump shotgun. Like, all right, do this and then do that. And oh man, these pens now, they're so easy. I don't feel like they're working hard enough to give their drug. Okay. So not amenables. I mean, there are some that needle phobia for sure. And some of the design of some of these agents or the pens are very much so that needle phobia is not a big deal because they can't see the needle. It's basically right up to their skin. They don't have to see it like going in. That can be an issue with this. All right. 3 milligrams once a day is a conditional recommendation. And because that's the dose they really want you to get to. But some people can't get to that with nausea and vomiting. They go to the 2.4. They still get pretty good weight loss. But it's daily. So that's a little bit of an issue. All right. Here we go. Yeah, I know y'all are waiting for this. See, if I put this at the front, then y'all sleep now. All right. So I have to save all these for the end. Right. So semaglutide, interesting drug. Right. We got PO now. Right. We got 2 sub-Qs, one for weight loss and one for diabetes. I'm talking about the sub-Q for weight loss today. What do y'all call it? What do y'all call the brand name? Wegovy or Wegovy? Wegovy. Yeah, I said Wegovy for a long time, and then I heard it sound Wegovy. I was like, okay, I guess it's Wegovy. All right. So initial approved in 2021. I remember this because one of my pharmacy students was doing their seminar on this topic. So it was approved in 2021. So 2 years ago this month. Okay. 2.4 milligrams sub-Q weekly. However, and I put in italics, slow titration. Right? You want to slowly titrate this, right? So this is essentially Ozempic, but higher doses, all right? So 0.25 for a month, 0.5 for a month, 1 for a month, and then 1.7. So it takes you really about 4 months before you can get ideally to that 2.4 milligram dose, which is what we're after for weight loss with the Wegovy. So, and this is where I want to point out average weight loss, diabetes versus non-diabetes. You can see a dramatic difference in some of these studies with the diabetes patients. They just don't lose as much weight. But hey, 6% is still really good. But I try to couch that with, because patients, when they come to talk to you, they've read a lot of stuff on the internet already, and they only see the highest numbers, right? They only see oh, I'm going to lose 20 kilograms, right? Or 40 pounds. Okay. So it's good to give them, appropriate expectations, right? And so one of the things we do is, hey, here are the expectations with this. Not FDA approved for diabetes. Okay. That's where you get Ozempic or Rybelsus. Now, when you see the commercials on TV, they do talk about the weight loss, but they don't say it's approved for weight loss. They'll just say, oh, by the way, they do lose weight, but it's not actually approved for that. And that becomes important, as y'all know, for insurance, right? Because insurance is not going to cover a drug for weight loss if it's not FDA approved. They're not even going to consider it, right? But do y'all have patients paying cash for this? Oh yeah, it's amazing to me. How much is this? How much is this prescription? $10. Oh, I'm sorry, I can't afford that. How much is this Wegovy? It'll be $1,000. Yeah, I can do that. And they do. They absolutely do. It just goes to show you, right? Yesterday, had a call, family friend, and it was a drug for C. difficile infection. I won't name the drug because we're not talking about it, but it's a good drug. It's an outstanding drug, but it was going to be $1,600 for her to pay for that, for her dad. And she's like, is there anything else out there? I don't know that I can afford $1,600. Now she could, but she's like, do I have to? So the pharmacoeconomic side of this is fascinating to me because this is like the one indication people will pay money for this and they'll pay cash, so it's interesting to watch. But I will say that long-term, if we're going to get buy-in and we want good outcomes, we really need to be covered for something reasonable. Yes, sir. What do you do and where are you located?
Oh, I'm from the Vegas area.
Okay, very good. Very good. Very good. Excellent. Welcome.
So what is your comment about this compounding pharmacies do glutide?
Yeah.
Because I say people who are running the weight loss business.
Okay.
In it, right?
All right.
But however, I think they're having some threat or issue because some of the compounding pharmacies are discontinuing doing the semaglutide because of the push of influential people,
Right.
that it's not FDA discouraging the public about it.
Right.
And then what's interesting about these people, influential people, are the ones who are the consultants of the pharmaceutical companies.
Mm-hmm. Yeah. So it's a good question. So the question for those on Zoom is about, what do you think about compounding of semaglutide, compared to the traditional routes of, the FDA approved dosage forms? So I'm not maybe the right guy to ask, and I'll tell you why. So I'm an ID guy, infectious diseases. And so I have seen many bad situations where compounding has occurred and there's been some contaminant in there. There's one going on right now, but the classic one was up in Boston when people were getting injected with Serratia from the steroid injections that they were getting in there. It's a tough situation because, I think that there are a lot of things that are compounded by pharmacists across the country that, hey, there's not, the whole idea behind compounding is you're compounding something that doesn't exist in that dosage form commercially. And so I get very leery but this is all demand, right? And I can tell you that I think some of this stems from, quite frankly, like it's embarrassing what pharmacists are being reimbursed for drug therapy, 10 cents for a prescription, losing money. And so independent pharmacies across the country are really trying to look for novel ways to generate business because a number of them are closing, which is PBM. Oh, blood pressure is good, even though I'm on phentermine. I'm just kidding. But so I would say, from that standpoint, I am very cautious, but I know what's driving it. What's driving it is demand. I mean, people, and you think about, compared to 25 years ago, there was no TikTok, there was no Facebook, there was no, Instagram, there were no influencers. And so messages like this were really a lot slower, but now it's taken off. So I know I personally, I'm more wanting to stay with the traditional dosage forms that are manufactured safely that I can get behind. But I know why people are frustrated because they can't find it. Right? They can't find it. Have y'all had those issues with people trying to find the drug and depending on the drug, especially the higher doses? So my friend that I mentioned earlier, she's on Mounjaro, which I'm going to talk about here in a second. And she was on, 7.5 for a long time because she couldn't find, the higher, because they were out. So they have these things on TikTok, like the Mounjaro journey, where people are like, it's almost like hey, I found it. CVS on Billy Bob Street. They got it. And then they go get it. And then they're out. And then it's like the same cycle again. So I've never seen anything like this before, I think, in my career that I can think of, where the demand is just so high that, but the manufacturers I know are working hard to like improve this, because long-term, when the data comes out and we've got outcome data, there's going to be a huge need for that. Yeah. Did you have any other comments? I didn't want to cut you off. I was just trying to answer it. Okay. All right. Okay. Yeah, it's tough. I get it. Yes, sir.
Nowadays, I live in a border town, so it's 800 for a 4-month supply in Mexico. So you can take a vacation.
Wow. Yeah, that is something I have heard about patients doing, overseas, the pricing differences and again, that's and so it's the actual manufacturer drug. It's just cheaper across the border. Right. Yeah. Yeah. Well, and I think that's an interesting point you make, because we've had that discussion before with other drugs and other talks. But it almost involves insurance. But a lot of people, this does not involve insurance. So it's really comes down to, okay, what cash price am I going to get this the cheapest? Yeah. I know, man. I thought, man, no way. I told my friend, she's like, yeah, people are paying $500, $1,000 for this. I was like, really? Every month? They're like, yeah. Weight loss, man, it's the ultimate outcome, I guess, for patient compliance. Oh, right. Okay. Now we're getting somewhere. Okay. Yeah. They're like, man, I can't get Mounjaro because I don't have diabetes. Not yet. But yeah. Oh, yeah. We used to have people in the bariatric surgery clinics, because, bariatric surgery is not FDA approved or not supported unless the BMI is 35 or more. Well, their BMI would be like 34. So all of a sudden, put a few pounds on, you qualify. So we had people doing that too. So yeah, you can't fake A1Cs, but you can try to get it up there, I guess. Yeah, you're right. They're like, man, I qualify. Why don't I qualify? Yeah, we get that in our clinic all the time.
And the insurance company will not pay for it.
Absolutely not.
There's an audit, and they go back to the doctor if they're not paid.
Absolutely. No, 100%. Okay. My friend's the one I told him to do something different. That $1,600 drug, she just texted me. So looks like we have a plan. All right. They're like, I know. They said, well, this is the best drug. I'm like, I know it is, but you want to pay $1,600? Do you want to make an announcement? All right, that's important with Wegovy. All right, so breakfast is up for 15 more minutes. So if you haven't taken your Wegovy, go ahead. All right, so no, I'm kidding. Anyway, yeah, not approved for diabetes. That's a fantastic point. What we're dealing with here is you got to have that. Right, if they audit you and they don't have it, whew, man, it's bad news. Bad news. So semaglutide, a lot of studies. Look at that average weight. This is fantastic. 87 to 113. When you add 13 to 87, what do you get? When you subtract 13 from 113. Like clockwork, baby. I love it. All right. So BMI is 25 to 30. Most of them are a little higher. Some of them had some lower BMIs, but I don't want to bore y'all with a ton of y'all have seen a lot of numbers here. Same stuff you've seen a lot of these. 3 studies use this really low dose, which is kind of pathetic, 0.4. But now most of these are getting up to the titration of 2.4. Again, a lot of these patients didn't have diabetes. 3 had a mixed population. 1 specifically looked at diabetes patients. Now we're getting into double digits, 10.8 kilos, right? So now we're talking about 20 plus pounds. That's a game changer for patients, right? When they see that double digit number, that clicks with them. no question. Better than placebo for any of those. I mean, look once you get to even 15%. So patients that were on semaglutide, they had an 8 times more chance than placebo of losing 15% of their body weight. That's a lot. Okay. So that's why you see these drugs, the injectable semaglutide, Ozempic for diabetes, Wegovy here, a lot of interest. Now, discontinuation rate was higher in the semaglutide patients. That makes sense. GI side effects, about twice as likely to discontinue due to a side effect. And we've got them listed there, kind of onesie twosies listed there. Most of these are not related to the drug, especially like acute MI was not related to the drug, but they have to list all of these. We actually do have a head-to-head trial, Wegovy and liraglutide, okay? And what they found, kind of the bottom line with this, is that the outcomes did favor semaglutide. So they had a mean weight change of about 15%, so about 15 pounds, right? 15 kilos, versus 6% with liraglutide. And patients that lost more than 10% of their total body weight did favor semaglutide, Wegovy, right? So that's why you don't probably see as much liraglutide anymore for weight loss, as there actually is a head-to-head trial. And quite frankly, you can give this, a lot less frequently. And so that's helpful for patients with injections. And believe it or not, the discontinuation rate was higher in the liraglutide group. And so a lot of, and in fact, GI side effects occurred in 8 and 10 patients overall. At some point, they reported nausea, vomiting, et cetera. But actually, discontinuation rate due to a side effect was nearly 4 times as higher in the Saxenda group. So I think a daily hit on GLP probably causes more nausea and vomiting. So it's interesting. Getting peaks, right? It's all about peaks of drug concentrations. What about pre-diabetes? Is this where we're going? Maybe. I mean, once they get diabetes, that cat's out of the bag, right? I mean, you've got, a lot of neurohormonal effects that are occurring, cardiometabolic. So step 1, 3, and 4, I think this is the next iteration of this, quite frankly, is looking at kind of pre-diabetes patients. They looked at over a course of a year, a little bit longer. They had a 20-week run-in period, though, a long time. They wanted to see if they were actually going to stay on this. And if you look at step 1, 3, and 4, you saw normal glycemia in about 90% of patients. That's something. In about 50%, 70% of others. So a lot more improvements. They also looked at this thing called HOMA, insulin resistance, and that also improved with the semaglutide. So the guidelines basically say maybe prioritize over all these other agents for long-term management. GI side effects, not uncommon, but if you titrate them, and patients, man, they're your partners, man. This is the one drug, they will go to bat with you. They will say, I know I've had a little nausea, but I want to keep going. It's amazing, right? Only all drugs are like that, all right? May cap at 2.4 if they can't tolerate the 3. Increased potential for adherence over Saxenda because of the weekly dosing. Oral could become a preferred agent. You're like, wait a minute, we haven't talked about oral. But wait, there's more. Now, so this is awaiting peer review publication. Now, I say all that to say, the industry a lot of times, and I'm glad they do this, they give a press release, okay? And it's like, here's what this was. And it's helpful, but I don't take any, I look at that, I'm presenting you with what was in that, but keep in mind, this has not been peer reviewed yet. Meaning it has not gone to somebody like me. I'm a associate editor at the Journal of the American Academy of Clinical Pharmacy. So I'm the one that reviews a lot of these papers. And, we have to ask for a lot more stuff before we will absolutely publish them. Okay. And sometimes we reject them. All right. It happens. Probably not something like this. I'm sure it'll get published. These studies are usually extremely well done. Now, they dose this 50 milligrams once a day versus placebo. It's interesting. You say Rybelsus. I don't know that they'll call it that. They may have a different name for it. I don't know. I don't know what they're going to do, but they could. I don't know. Rybelsi. I'm not sure. In my retirement job, that's what I want to do is name drugs. I think that would be so cool. you know, because some of these names are terrible. Let's just like the COVID vaccine for Pfizer, right? Comirnaty. What is that? That is the worst name of any drug I've ever heard, I think, right? Then you got like Baycol. That used to be Cerevastatin. Y'all remember that drug called Rhabdo? All right. But Baycol, Bayer cholesterol. That makes sense. Lasix, last 6 hours. Right? Makes sense. Okay. Some of these drugs, I'm like, I have no idea where you get your brand name. But anyway, so 15% weight loss in the OASIS 1 study through 68 weeks. Nearly 9 out of 10 achieved 5%. 2 out of 3 for placebo. So it was comparable to the step 1 trial, which was the injectable semaglutide. So more to come, but now we got an oral dosage form that I think, you know, if somebody gets an oral dosage form that's as effective as some of these injectables, they definitely will get some play. All right. But more to follow. It's too early for me to give you anything, but I want you to know that this should be published hopefully soon. And then we can get a little bit more detail. You're probably right. I mean, as competition comes about, I definitely could see that happening. It'll be interesting. I mean, it's $100 billion business. But I do think, you know, the nice thing is, I do think as long as, that's why we need the longer term outcome studies to really help us delineate, but there's going to be room for a lot of these agents. So the final guideline kind of recommendation, semaglutide, I put an asterisk by because that's kind of the more preferred agent for the FDA approved weight loss drugs. Now, obviously there's one we're about to talk about that could change things. Okay. So liraglutide, the others, not as much, but these are moderate certainty with the nod going to Wegovy. Now, something that's been kind of not out there yet, but I want you to know it's coming. Okay. So y'all on LinkedIn? I don't even know if y'all know what that is. All right. So Microsoft bought it years ago and it's pretty interesting. Well, I like it, but I get asked to do these like consulting surveys all the time. And this is the latest one. I literally got 2 in 1 week, small molecule GLP-1s. And I was like, what the heck is small molecule GLP-1s? So I did my own research. Okay. So essentially what these are is exactly what it says. It's just a smaller molecule of GLP-1. The idea is maybe for better tolerability. It gets it into an oral dosage form. Could it work? So this is a phase 2b study. 6 groups phase 2 studies are all dose finding, right? So they're trying to find the dose that actually works. So they looked at 2.5, 10, 40, 80, 120 milligrams, but I highlighted something I think is important. BID. Right. So that's one thing that's going to potentially, in my view, be an issue is BID dosing. Now, if you pull old pharm studies and they'll say once a day BID, there's not a significant difference in adherence. I beg to differ. I think anything more than once a day, especially in this area, could be problematic. But it is twice a day. So they weekly escalated. They looked at A1C, glucose, body weight. Doses below 80 milligrams did not show a difference in weight loss. So my hunch is going forward with phase 3 trials, they're going to be looking at 80 and 120 primarily. And my hunch is, I don't know, they may use the others to titrate just to get people like used to the drug, but they're really going to be looking at this 80 and 120. And the doses below 80 and 120 did not show a difference in weight loss. And you see the weight loss, 2 kilograms for the 80, 4 for 120. So it doesn't sound like super impressive, but there's a caveat. And I'll show you that here in a second. And here it is actually. And that is, this is a short study, 16 weeks, right? What are all the studies we've been talking about, right? A year long. So you really can't compare it yet. It's early. I think this is a dose finding study. This is not an outcome study. This is just here's our doses. We're trying to see what happens. Okay. Nothing near the data that we have for like a semaglutide, right? So it is an oral drug. The weight loss is not as much, but it was only for 16 weeks. It is actually similar to some of the injectables at week 16. Longer term data, more to come, but I want you to know it's out there and it's probably coming. Something you need to be on the lookout for watching longer term. Yes, sir.
Small GLP-1 because amino acids at the beginning, they're going to affect and the stability. So is that instead of the long term?
Yeah, so the question here for those on Zoom is just about more the chemistry and how this is. I'll be honest with you, if I told you an answer, I'd be making it up. I really don't have a good sense for like, I've been trying to find some more, but I've got to do some more research on that. And honestly, like I have a rule, like I don't dig too deep into these drugs until they get FDA approved, but I want to see a phase 3 study before I start investing my time, but they are coming. I mean, there's a number of these out there. That $100 billion number I gave you earlier talked about the small molecule GLP-1s, but again, it is oral. And so that obviously anytime you get an oral agent, that's going to be something to keep an eye on. Now, patient case. So KM is a 37-year-old female with diabetes. So they don't even have to fake it. Okay. They have diabetes. And they're like, this is the only population they want diabetes. You're right. No one wants diabetes. Okay. She's a teacher with prescription benefits through her employer. She's been stable on semaglutide 1 milligram once a week for the last 6 months. She's also on maximum tolerated metformin. Her BMI decreased from 35 to 31, and her A1C has dropped from 8.5 to 7.2. Pretty good, right? Despite her progress, she's a little frustrated because she really wants to lose more weight. She really wants to get more down to a BMI around 25. She recently saw a commercial from Mounjaro and said, I would like to discuss the option of switching to this medication. All right. So let's talk about Mounjaro a little bit. So what are the 2 drugs y'all get asked about the most for weight loss? Is this one of them? Okay. By far, right? So Mounjaro, Ozempic, Wegovy. I would say those are the 3 I get the most questions about from our patients and really from our providers too. So Mounjaro is a first in class. So it's a GLP-1, but it's also this long thing that most people after a while just call GIP, but glucose-dependent insulin-atropic polypeptide. Okay, so they call it a dual agent. All right, and the idea is that it has a dual mechanism of action. The GIP part may be helpful in the sense that less nausea and vomiting, less GI side effects, and overall improved tolerability. And so that I think long-term could be an advantage for this going forward. It is FDA approved for diabetes. That's kind of where we sit right now. The A1C data, when it's been compared, has been better than Ozempic, Tracebo, which is an insulin product, or Lantus in studies that are about a year long. Again, you start at the 2.5. You titrate usually to 15 milligrams once a weekly. Again, this is for diabetes. So I'm just giving you kind of the background on diabetes because this is not FDA approved for weight loss yet. Okay, we'll talk about that. Barrier contraceptive for 4 weeks after initiation and dose escalation. That's in the package insert. It's a known thing. Probably the GLP-1 should have it as well, but it is in there. Now, the question everybody asks is, what about weight loss? All right, what about weight loss? So the SURMOUNT-1 study, this was, it's been out for a little bit now. This looked at non-diabetes patients. So no diabetes, right? And so they had those BMI criteria that we've seen across the studies. And they looked at 5, 10, and 15 milligrams. They followed them for about a year, actually a year and some change, 72 weeks. And they found a 15%, a 20%, and a 21% weight loss compared to placebo. Tremendous, right? And this is what kind of got people interested, seeing these results, the better tolerability compared to some of the GLP-1s. And so patients really started doing this. If you go on TikTok, actually, there are people, they do their Mounjaro journey. I don't know if you ever heard of this, but it's like almost like a focus group that patients get together to kind of help encourage them in their weight loss journey. And they call it the Mounjaro journey. It's just people on that. I promise Eli Lilly didn't come up with that, but the patients did, and that's what they did. So kind of what I said earlier about this is only a press release. It's not peer reviewed, at least by the time I turned in my slides 2 weeks ago. Now the SURMOUNT-2 study is out with this agent. So it's awaiting peer review publication. So instead of looking at the lower doses, this one looked at 10 milligrams and 15 milligrams specifically for weight loss. And it did include type 2 diabetes, and they still lost about 15% of their body weight, even in diabetes patients. So that's kind of interesting because in some of the earlier GLP-1s, they didn't lose as much in the diabetes arm versus the non-diabetes studies. So maybe this holds out a little bit better in the diabetes patients. I mean, looking at this is FDA approved for diabetes. And so we've already got a pretty rich history of people using it in diabetes and then watching their weight loss. kind of not surprising. So 8 out of 10 patients achieved at least a 5% weight reduction, and only 3 out of 10 for placebo. So where do we go from here? I think this agent, I've seen a lot of people use it off label, pay cash for it, etc. Using some of these coupons. We'll talk about that in a second. But I think by the end of the year, we'll have an answer on whether this is going to be approved or not, because the information has been turned in. It's just a matter of FDA waiting and getting through it. But this is probably going to be a high priority drug, just because it's interesting. You bring up the compounding. I think that may speed it up, because in reality, we know patients are getting compounded materials, and it may or may, if there's a bad outcome with that, of course, that could have been prevented. That would be good. Yes, sir. Yeah, absolutely. Yeah. And that could be show some of the benefits in the diabetes patients as well. Kind of yeah, definitely. So going back to our patient. So the question she asked about Mounjaro. Okay. So a couple things. Mounjaro's A1C reduction. Remember, this patient has diabetes. So the Mounjaro A1C reduction is a little bit more, 2.3% versus 1.9, pretty close. Okay. She's had a pretty good response to the semaglutide. The weight loss was 24, almost 25 pounds with the highest dose, compared to 12.5 with semaglutide. So keeping in mind, that was 1 milligram of semaglutide, not the higher dose that's typically used with Wegovy. Okay. So it is a reasonable attempt to switch. From an insurance standpoint, because they have diabetes, they could actually get that covered. If they didn't have diabetes, it's a no-go. But because they have diabetes, there is a 1-year trial through the manufacturer. Hard getting that now is nearly impossible, though. I can tell you it's out there, but there are some more comprehensive and expansive copay programs. What are y'all's patients using? Are they using any of the cards or any of the coupons? Coupons, right? Yeah. So they are out there. Sometimes it takes a little work, but they are out there, and patients are very motivated. So we find them. So kind of gone through this. Again, not indicated. I've gone through this already. Plenity, I include this only for completion. I don't know how much it's going to get used. It's a cellulose and citric acid, kind of non-systemic. It's kind of like improved Xenical, I guess. You give with water before lunch, weight loss about 6%. Again, not much difference than placebo. So I'm just more including this for completion. For CE, still some significant GI side effects. All right, one more case to kind of close us out for this talk. So DL is a 50-year-old male with a past medical history of obesity, seizure disorder, and a stroke, which occurred 5 years ago. All of his labs are within normal limits, and he reports 1 episode of pancreatitis that occurred when he was 30 years old after attending a bachelor party. He's not consumed alcohol or used tobacco in over a decade. No other GI abnormalities or concerns. His work schedule fluctuates greatly from day to day, making it difficult for him to establish a consistent routine. However, he really wants to lose weight, and so he's trying to make some lifestyle changes. So which of these options is most appropriate for DL? So we've got the Contrave, we've got the Qsema, we've got the Saxenda, and we've got the Wegovy. So any concerns with these agents? Exactly. Okay. So Wellbutrin with seizures is a big problem, mainly with the higher doses of Wellbutrin, but anybody with a known seizure history, not going to be a great drug. Yep. So that would be low on my list. Yeah, exactly. The phentermine. So this guy has hypertension. So as we saw in the studies, depending on the degree of his hypertension, if he gets a good response from the drug, his blood pressure may drop. But at the same time, the thing that's even more concerning to me is he's already had a stroke. And so with him already proving that he's had some sort of constrictive CVA, I'm probably going to be less likely to do that. If it was just hypertension, I think I'd be a little bit more likely to do that. But yeah, you guys hit that. The once daily versus once weekly with the GLP-1s, I think a once weekly option would probably be ideal for him because of his kind of haphazard schedule. The pancreatitis is interesting. I just kind of threw that in at the end, like 10 years ago after a bachelor party. He's probably just drinking too much, right? And got pancreatitis. It's something I keep in the back of my mind, but it probably would not restrict me from doing that. So key evidence gaps. What are we looking at long term? So for the GLP-1s and for Mounjaro, the things I'm looking for are A, what are the long-term outcomes of these drugs? When we're using these, because these drugs, the weight loss goes away when you're not on them. So these are drugs you're going to have. It's kind of like a statin, right? What did we find out with statins? If you take them long enough, they give you diabetes, right? So that it can happen. But cardiovascular events, cancer risk, right? Because GLP-1s, they are contraindicated in certain thyroid C-cell type tumors. So is there a potential risk for long-term use? It'll be interesting because, we know losing weight helps with cancer risk. And so, but is there some sort of cancer out there that we're not aware of that if you're on this drug every week for years, could it come about? We don't know the answer to that yet. All of our data is within a year, usually 72 weeks. Comparative versus other meds or bariatric surgery. So, if you go head to head bariatric surgery, you're going to lose more weight. But we know that not every patient's a good candidate for bariatric surgery. Psychiatric illness is a big contraindication. Can come about. So this offers a lot of patients another option. Yeah.
They depend on, and they have a lot of low receptors in the thyroid as well as bone inflammation. So we don't have that many T cells. So we don't have those T cell receptors. So basically, it's a rat thing, and we're not rats.
Yeah, it was on Zoom. I had a very good explanation of why the thyroid tumors are more of a concern in rats due to their having more C cells. Yeah, I think that's true. What I don't know is, are there other things out there that are specific to humans that unless we use it for a long time, we're going to find out. So look, I'm very hopeful, but I've been burned before. And so I want to keep it real. And I think the FDA is going to make people do that as well. Yeah. And then disparate populations. That's the other thing with these. These are mainly white females in these trials. Like we really need a lot more data in men and other populations because there's a lot of populations worldwide that struggle with obesity. How well do these work in those populations? I don't know. And so that to me would be a tremendous go is for some of these companies now that they've got some working capital from sales to go out and do these trials specifically in Asian populations, other populations, Latino populations, African-American, whoever outside of just Caucasian females. So I think that's the next step. You want to make a comment?
Yeah, it's like Mexican-American of BMI of 45.
Right.
So,
absolutely. Yeah. It's a no-brainer. So yeah, so that's good. So yeah, this is my summary slide. So very interesting topic. I love it.